Everybody able to see that okay?
Looks good. Thank you.
Great. Well, thank you very much. And thank you to all of you for tuning in today for the 12th session in this series of our OIF, OI Echo sessions. Thank you to my co-faculty and a tremendous thank you to the OI Foundation. We'll move on here. No relevant disclosures for this talk. These are the topics we've covered so far during the OIF OI Tele Echo series. And if you've missed any of these or would like to review any of them at any time, the recorded sessions are available on the OIF website and would encourage you to use these as a reference. At this point in the series, we've certainly covered the fact that type 1 collagen is widespread throughout the body. And for this reason, there really are very many extraskeletal manifestations of OI. And each of these manifestations plays a very important role in the multidisciplinary management of OI patients at each and every age. We feel that a multidisciplinary team is best suited to manage these complex manifestations, certainly including medical management and a number of other specialties. And we always need to keep in mind, orthopedics is really only one piece of this multidisciplinary puzzle. There are many orthopedic manifestations of OI as well. We won't go through each and every one of these on this list today, but we will cover a few of these that present particular challenges to us as orthopedic surgeons. What are our goals of orthopedic treatment of each and every OI patient? Well, we'd like to help each child or adult maximize his or her individual function, achieve developmental milestones as close as possible to the peer group, and in the process, decrease deformity and fracture burden. And in other words, kids should be kids. During the prior sessions, Dr. Wallace covered lower extremity realignment and rotting absolutely beautifully. So again, I refer you to her talk to go over that topic. I discussed upper extremity management in the setting of OI. Dr. Shukin Shah, one of my partners on our OI team, discussed basilar invagination and ways to diagnose and manage basilar invagination. And Dr. Jeanne from Montreal reviewed the management of scoliosis and spine deformities in the setting of OI. So that brings us to today's topic. What are some of the things that challenge us the most as orthopedic surgeons in the treatment of our OI patients? And even more importantly, what are some of the items in our toolbox that we can use to address these challenges? I cannot emphasize enough that our orthopedic outcomes, our surgical outcomes, are very much dependent on optimizing medical management and really optimizing each patient's muscle strength and overall bone quality. Again, that's with the use of routine, safe exercises, vitamin D and nutritional optimization, optimization of bone density, bisphosphonates or other medical treatments when appropriate, and really an individualized care plan for each patient. And when thinking of these surgeries that we'll discuss for the majority of this talk, it's very important to remember that the surgical procedure is one small part of the overall perioperative care, and that it really does take a team approach to optimize the outcomes. The OR team, it's a big team in the OR really working together as a cohesive unit. And it's important for each member of the team to be familiar with OI and ways of handling fragile and complex patients. Anesthesiologists play an absolutely critical role. I know some of the other large OI centers and our center uses quite a bit of regional anesthesia for these cases to help with overall pain management. Neuromonitoring is something that we will use in select instances. And this is a way of monitoring nerve function and the spinal cord health during an anesthetic event. The pain team plays an important role in helping each patient manage and control pain. Pediatricians and other medical doctors to help us manage the other aspects of care other than the surgical ones. And of course, physical therapy and occupational therapy. When we speak of these challenges, this list here is what we'll be focusing on for the rest of our time. I would say one of the most common ones that we face is a revision surgery, and that's a surgery that's being done after an initial surgery has already been performed. And then we'll touch on stress shielding, non-unions, various deformities about the hip, femoral neck fractures, a few things with the elbow, and trauma in the setting of OI. Moving on to revision surgery. Some of the most common indications to be doing a surgery in a revision setting would be growth. And growth is actually a positive reason to be doing a revision surgery. It means that the child is growing and developing nicely, and that's a positive reason to be revising a long bone rodding. And then there's others as well. Rods don't always behave as we'd like them to. Rod migration, fractures with significant displacement or bending of a rod. Open fractures are rare in the setting of OI. That's when the bone has come out through the skin, but that is a surgical indication for sure. Certain degree of bending of a rod, non-unions that are causing symptoms, and we'll touch upon those in just a little bit. And again, each of these is very patient and case specific. This is an example of a telescopic rod that has performed very nicely with a period of growth. We can see the female component has remained well fixed in the proximal aspect of the femur. Distally, the male component of the rod has also remained fixed. And over time, each of these pieces of rod has telescoped apart with growth. This is another example of a telescopic rod that has behaved well. Over time, the junction of the two components of the rod has moved up into the diaphysis, or the narrow portion of the bone. And this was an indication to revise to a longer female component of the telescopic rod. Now, the rod doesn't always behave, as I mentioned, as would like it to. Each of the components does not always remain fixed within the epiphysis, and we can think of that as a rod migrating over time. But what's probably more likely happening is that the bone itself is overgrowing that part of the rod. We can see this here in the proximal femur. We can see this here in the distal femur. Now, these findings on X-ray are not always in and of themselves an indication to perform a revision surgery, but this is something that we monitor over time and can certainly play a role in the technical aspects of performing the revision, and involve various tricks in how to get through that part of the bone to the rod that needs to be revised. This is an example of a telescopic rod in the tibia of an 11-year-old girl that did not remain fixed down in the epiphysis distally or in the epiphysis proximally. It did do its job for quite a few years, but then she sustained a fracture, as you can see in this blown up image here at the distal aspect of the rod, which was an indication to revise to a slightly larger and different telescopic rod. Another reason for a revision surgery would be rod migration into a joint. This young man has very severe OI, and this non-threaded, non-telescopic rod in the tibia, without an inciting traumatic event, migrated proximally into the knee. You can imagine this caused an issue with knee range of motion and caused discomfort. And the revision in this instance included revising to a threaded, non-telescopic rod. And I've circled the threads here in yellow because this was the particular tool in the toolbox to avoid the same type of migration happening again. Now, this not being a telescopic rod, we do expect him to grow off the rod distally over time. Now, rods do bend and break. I don't think there's really any rod out there that hasn't been shown to do so. This is a 13-year-old young man who had had a telescopic rod in place for quite a few years, fell at school, felt a snap, presented with this left lower extremity deformity and this bent rod. And again, this was an indication to revise to a slightly larger telescopic rod as shown on the right side here. So that brings up the question, if rods that are too small have a tendency to bend and break, as another dramatic example of a bent rod shown here, well, then why not use the biggest rod we can? And this brings up a very important point and another challenge on the list to discuss. The reason is because if the rod is too big, and we'll get at what too big might mean, it introduces a problem and a challenge that's actually even more difficult to manage than a bent rod. And this is called stress shielding. So what is stress shielding? It's bone loss along the length of a rod, as shown in these three images here. It happens in the setting of a rod on the inside of the canal. And as the bone is essentially absorbed over time, there's very little bone around the rod. That bone is weaker. And as you can imagine, with less bone to work with, a revision surgery will be significantly more challenging. This is a dramatic example of stress shielding. This is a 13-year-old young woman. This is a patient we share with Dr. Marini. And you can see here, the right femur has quite a good bone stock, whereas the left femur has this large diameter rod in place. It's a 5.6 millimeter telescopic rod that had been placed at the age of 5 years old. And over time, there's very, very little bone around this big rod in the left femur, whereas you can see the right femur is not so. This is a figure that shows this evolution of stress shielding over time, the right femur on the top row here and the left femur on the bottom row, where you can see at one point it had quite significantly good bone stock. And then over time, with this large rod in place, we see this dramatic stress shielding. At age 14, we performed a revision due to a fracture that she had sustained. We downsized to a 4 millimeter rod, bone grafted along the length of the canal, added bone graft at the osteotomy site here, used a plate and screw construct as supplemental fixation. And over time, with restoration of the alignment and incorporation of the bone graft, and we think also a response to downsizing the rod, we can see that the bone around the rod significantly improved. This is a 2-year post-operative follow-up. And again, the bone around the rod is fairly significantly improved, as shown here. So this is really the Goldilocks phenomenon of not using a rod that's too small, that is more prone to bend and break, not using the largest rod that can be fit in a bone. And Dr. Fassier really said it well. Remember, the child needs more bone than metal. Moving on to the next challenge on the list. The next significant challenge we'll discuss is non-union. And this has been fairly well described in the orthopedic literature in the setting of OI. And you know, it introduces two questions that are important. One, what is a non-union? How exactly do we define a fracture or an osteotomy that hasn't healed? And is it causing any symptoms? This is an example of one of our patients with rods in all 4 segments of the lower extremities. And zooming in here on the left tibia, you can see this line here, which is a remnant of one of the osteotomy sites. Now, radiographically, that may be considered a non-union or a not fully healed osteotomy, but without any symptoms, doesn't necessarily require any intervention. And when we do work up patients for non-unions and treat them surgically, we need to adhere to our orthopedic principles of non-union management. Always evaluate the host or the patient, the nutritional status. Is there an underlying infection? Smoke exposure can play a very significant role in developing a non-union or having trouble healing a fracture site. And then we need to consider our fixation and the biology of the fracture or non-union site, and how can we encourage it to heal. So this is where we think of tools in the toolbox, and supplemental plates and screws we've alluded to in a few of the prior examples, but this is an important tool in the toolbox that can be helpful to give stability and additional fixation to a non-union site. This was beautifully described by Dr. Esposito and his team in Omaha. This was one of the first reports in the literature. And he described the use of a supplemental plate and screw construct to address a distal humerus non-union. As we covered in the upper extremity talk, the distal humerus down by the elbow is a very common site to develop non-unions. And that has given us a good tool for those. And then In-Ho Choi and his group in Korea have also described the use of supplemental plate and screw constructs. We've reviewed our data as well and are working on updating that now. This is a case example of a 23-year-old young man, severe OI, and a long-standing non-union of the left humerus, had been operated on multiple times. And there was also a radial nerve palsy. And in addition to addressing this non-union site, we performed a radial nerve neurolysis, repaired the non-union. We did use a supplemental plate and screw construct because it was very rotationally unstable, and fortunately went on to heal. And by freeing the radial nerve from the bed of scar tissue, we were able to regain some function from that nerve. And I mentioned the radial nerve. In the setting of these distal humerus non-unions, this is actually a different surgery, but it shows that almost without fail, the radial nerve is passing right at the site of the distal humerus non-union, and its management can actually, and protection can actually be the most challenging part of these cases. So that's important to keep in mind. Gap non-unions are a subset of non-unions that are very challenging to manage. This is an example here of a gap non-union in both the right humerus and the left humerus of a young girl with very severe OI. And you can see the ends of the bones are very atrophic, and there's a large area in between the bone segments with fibrous tissue. I would love to hear some thoughts from the audience on any experience working in and around these types of non-unions. This is not as dramatic of a gap non-union. This is a 13-year-old young girl who developed a non-union in the proximal tibia, and with that instability there over time fatigued and broke both components of the telescopic rod. These are some of the tools we use to address it. In revising the intramedullary rod, we did not need a telescopic rod because there was just about no growth left. Used a transfixion pin proximally because the bone quality was quite poor. In addition to the supplemental plate and screw construct here, we used both allograft bone and demineralized bone matrix, again, to give some structural support as well as augment the biology. And then we also used the allograft bone distally because the canal was very capacious and to give some support around the rod. These are the 5-month post-operative x-rays. Fortunately, clinically healed without discomfort at that time. So that brings up structural allograft as really another tool in the toolbox, and one way we think of it as a way to provide additional supplemental fixation. This has been described in all different parts of the world in this setting of OI, and it's an important tool to keep in mind. We reviewed our use of structural bone graft here and categorized it for a couple different reasons, but really to try to create a framework so that we can further study it and look at our outcomes a little bit more critically. The different categories we came up with, we think of it as being used as an interpositional allograft to fill a segmental defect, or as an onlay allograft to provide structural support, oftentimes needing either a cerclage or plate and screws to hold it in place. Inlay is what we thought of as the allograft used to give support in a capacious canal, kind of like a shim, and blocking allograft to help prevent rod migration. So moving on from the allograft, we'll next talk about deformities in and around the hip. Coxa is an important one to mention. Here is shown a 30-month-old patient without OI, and these yellow lines form what we call the neck shaft angle, and that's typically about 125, 130 degrees. And again, that's a patient without OI. This young man at 28 months old here on the right of your screen has moderate OI. And you can see the neck shaft angle is quite reduced, approaching 90 degrees. And not only that, but there's really poor ossification of the femoral neck here. It's important to distinguish true coxa vara versus apparent coxa vara. This is actually, in these figures, the same patient, but in a different position. So the bowing of the femur and how the patient is positioned can sometimes be misleading. And again, Dr. Fassier described in his paper the proper positioning to obtain an X-ray to determine true coxa vara. And why does it matter? Well, it does affect gait. It affects hip range of motion. It can be progressive over time. And Dr. Fassier described a very elegant technique to address and fix the coxa vara in the setting of an intramedullary rod. And in the older patient, there are some other fixation options as well. Not going to dwell on too many coxa vara cases here. I know Dr. Wallace in the case discussion part of this has a few beautiful cases to show, so we'll save those for the latter part of the session. Another very challenging deformity in and around the hip is something called acetabular protrusio. And this is a dramatic envelopment of the femoral head into the pelvis. And for comparison, these are age-matched patients again. This is a 15-year-old girl without OI on the left side of your screen. And on the right side of your screen, also a 15-year-old girl with OI, you can see has had a spinal fusion here. And the femoral heads have been enveloped literally within the pelvis. And you can see the pelvis itself has also developed a significant deformity over time. This is an example of a model bone not affected by OI to give you a sense of how a pelvis typically looks. And then this is a 3D printed model of a CT scan of one of our patients with dramatic acetabular protrusio. And, part of the issue, as you can imagine, is, there's a lot of important organs that need to live between here and here. And this can really have a lot of clinical ramifications, even additional to orthopedic issues. We tend to find clinically that severe acetabular protrusio is even more challenging for the patients with fusion to the pelvis, because again, a fusion to the pelvis takes away yet another motion segment. And that can leave the very limited motion of the hips and place the femoral necks at significant risk for pain and fracture. This is a 21-year-old young man who has severe acetabular protrusio, does have a fusion to the pelvis, and presented to us with a few issues. One, an inability to transfer, and two, severe impingement pain from the top of the proximal femur here, literally banging into or abutting into the pelvis. And with significant rehab and various physical therapy tips and tricks, worked with him on his transfer abilities, and used this 3D model to guide a surgery to resect part of the greater trochanter that was causing that very painful impingement. So we do find these 3D models to be helpful. Of course, understanding that they require a CT scan, which is radiation that needs to be considered in the balancing risks and benefits. Acetabular Protrusio has also been described well in the literature. These are two series. One from Montreal and one from HSS. And again, describing the effect on range of motion, hip pain, gait. And another issue is, as we mentioned, the femoral neck is placed at risk because it's moving within this very small confine, and femoral neck fractures can be very painful and difficult to manage. This is an example of a 16-year-old girl, actually the same as she was 15 in the other x-ray we just looked at, with longstanding left groin pain, and took a misstep down from a camper and felt significant acute on chronic sharp pain in the left groin. And this arrow here is pointing out a fairly subtle femoral neck fracture on the left side there. We get a CT scan here for a couple reasons. One, to better understand the fracture pattern. Two, to understand the size and shape and anatomy of the femoral neck, where we need to place our fixation. And the third thing is, very interestingly, you can see right around this fracture site, there's very significant sclerosis there. So for a long time, this bone had been placed at stress. So it's certainly a risk to have this fracture. And that also affects the ability of that bone to heal. The revision procedure included revising the intermedullary nail. As you can see, it had it had come away from the bone over a period of years. So we placed fixation in the femoral neck. We were able to fit one screw and one threaded wire. And then, so as not to put the femoral neck at any more risk during the case, we did the revision, realignment and rodding from a retrograde approach, so up through the knee, and that's shown here. And again, these can take time to heal. At 3 months, clinically, she was feeling well, and you can still on x-ray make out a little bit of a fracture line there. We think that sclerosis certainly affects the healing time. And then unfortunately, 1 year later, no prodromal symptoms on this side, bent over to pet her dog, and sustained very similar non-displaced right femoral neck fracture. Again, the CT scan shows fairly dramatic sclerosis around the fracture site and helped plan fixation. On this side, we were able to fit two screws as opposed to the one screw and the threaded K-wire. This is 4 months post-operatively, fortunately clinically back to baseline. We tend to feel that this protrusio phenomenon is not isolated to the pelvis. You can see here an example of it in the shoulder as well. This is a 17-year-old with severe OI as compared to 17-year-old without OI. And we find that it has very similar clinical implications, affects range of motion. It can affect the ability to do rodding of the humerus from an antegrade approach down through the shoulder, and can be very clinically significant, particularly for the more severely affected patients who are really dependent on upper extremities for day-to-day function, and then also athletic activities. While we're on the upper extremity, this is a discussion of a condition in the elbow that is clinically important, called radial head dislocation. So this is an elbow of a patient with more mild OI who has a located radial head. So this is the proximal radius here, lining up nicely with the capitellum. And this is another example lining up on the lateral view, same patient here on the left side. And then this is a different patient with type 5 OI on the right side. You can see the radial head is nowhere near the capitellum. It's in a different zip code, as also shown here on the lateral view. And clinically, this is important because there can be a prominent or painful bump. The range of motion is affected, and it can cause both discomfort and limit day-to-day functional abilities. This was well described by Dr. Fassier, Dr. Rauch, and their team in Montreal in this review of almost 500 upper limbs. The radial head malalignment was significantly higher in the folks with type 5 OI. And then this can also be compounded and clinically affected by the calcification of the interosseous membrane in the type 5 OI patients. This is one of our patients with type 5 OI, teenager who had actually had prior surgery for the right elbow to try to resect the radial head and give more range of motion to the elbow. But unfortunately, that type of surgery in patients with type 5 OI tends not to have a lasting positive effect. On this right elbow side, the arc of motion is from about 45 to 60 degrees of flexion, very little ability to pronate or supinate the forearm. And then on the left side here, different position of the arm, more extended, but again, only able to move from about 10 to 25 degrees of flexion and very little ability to pronate and supinate. And I bring this topic up because a lot of what we've talked about in this talk are, surgical approaches to these challenges, but there are instances when we need to recognize the significant limitations of a surgery and when it can cause more trouble in the setting of the hyperplastic form of type 5 OI and not necessarily have a good outcome. And the positive thing about this is, there's many ways that adaptive devices can be used and patients can figure out ways. This is the patient who gave permission for the videos to be used, showing how he's adapted to this motion. And various occupational therapists have helped. That's my favorite one, putting in the AirPods and various devices that can be helpful on a day-to-day basis. And then the last topic I'll touch on, so we have time for the cases, is trauma or fractures in the setting of OI in the slightly older patients, and challenges that certainly may be faced at a center that's used to doing trauma with unaffected folks with typical sized bones. So this is a right femur fracture in a 30-year-old young woman. She is ambulatory, and like many young adults, had fairly routine care as a child, but moved on and different focuses in life, and presented with this right femur fracture and in the setting of this small intramedullary rod. So when we look at it, we're used to looking through the lens of OI bone, but what are the challenges here? Well, the canal is very small. This is only a 4 millimeter rod that's in the femur. And to give you an example, most adult trauma nails or even pediatric femur trauma nails that you'd use once done growing really start at about 8 or 8.5 millimeters. So, much smaller canal. Some of the bone proximally is very sclerotic, very dense around that rod, yet distally very brittle. We did a nutritional workup and vitamin D came back at undetectable, less than 6. So that's going to give a challenge healing. There are pain management issues and, different psychosocial support issues for, a young adult in this stage of life affected by such a trauma. This was our reconstruction here. Again, we used fairly significant allograft to help at the fracture site. And again, that psychosocial support is an important part of the puzzle. So the last slide here, to recap and sort of talk about some of the challenges right now and our future directions. Again, really treating each patient as an individual, assessing functional goals and working as a team to help meet those goals. We as orthopedists need to challenge ourselves to better understand not only the genotype-phenotype relationship, but really the response to our orthopedic interventions in the setting of different mutations, and better evaluate our outcomes. We're making an effort to focus more and more on patient-reported outcomes and how our orthopedic interventions affect quality of life. We need more standardized ways of looking at complications. What is a non-union? How do we define that? How do we compare those from center to center? And again, the psychosocial support component of this, especially in today's day and age, with the pandemic, is absolutely critical. So we've incorporated the promise into our clinic. Fortunately, it's now able to be within an electronic medical record. We're making an effort to gather better baseline data to be able to monitor progress in and around surgeries and fractures, correlate that with functional outcome measures. And again, the psychology and support for patients is important. We've made an effort to add that as part of our clinic team when needed. So thanks for your time and attention. Big thanks to our team here at Nemours. That was during OI week. And this is my email address for any questions that come up after this session. With that, let's open it up to questions and answers.